I want to Kenji again, and this module is the spine, chapter 4. Kind of skipped it in our class structure, but we're going to go back and complete chapter 4 now. This is a shaded surface display CT image of the T-spine with some pathology there. We're starting on page 172. The spine functions to protect the delicate sensory and motor nerves that allow for peripheral sensations and body movement. Sensory and neurologic loss can be a result of injury or pathologic abnormalities of any of the many areas that constitute the normal anatomy of the region. It's important that we understand sectional anatomy of the spine. It may be able to save function to somebody someday. Just recently, I did a CT of a person who was in an automobile accident, the vehicle rolled over. I'm not sure if the individual was checked out by the emergency medical technician or emergency medicine, but they were allowed to go home and sleep. The patient continued to have neck pain and came into the facility for evaluation, in which we did a CT of the C-spine and found out that there was indeed a fracture. That's not totally uncommon. However, the fracture involved a piece of the transverse process lodged inside of the spinal canal, abutting the spinal cord. This individual was extremely lucky to have not lost lower extremity function secondary to this type of injury. The patient was presented without a C-collar simply because the accident happened the night before and the patient went home. So therefore, many people would not believe that this type of incident could happen. However, it did. Immediately put a C-collar on the patient, and the patient went to shock trauma. However, if you were not competent enough to understand that a chip of bone is lodged against the vertebral column, the spinal column or spinal cord itself, then you may just perform the procedure, send the patient back, and who knows what will happen down the line with medical evaluations and everything else, trying to ascertain what's going on with the patient. The patient might have ended up being paralyzed. That's why it's incredibly important to understand sectional anatomy, and what you do is just not understanding what's the beginning and end point, but understanding what should be there so that you understand what doesn't look right, and you can bring it to the proper person's attention, a doctor, ER doctor, radiologist. Okay, the vertebral column is a remarkable structure that supports the weight of the body, helps to maintain posture, and protects the delicate spinal cord and nerves. The cervical and lumbar sections convex forward, creating lordotic curves, and the thoracic and sacral sections convex backwards, creating kyphotic curves. Vertebrae vary in size and shape from section to section, but a typical vertebra consists of two main parts: the body, the anterior element, and the vertebral arch, the posterior element. The compact bone on the superior and inferior surfaces of the body is called the vertebral end plate. Located posteriorly is the ring-like arch that attaches to the sides of the body, creating a space called the vertebral foramen. The two pedicles project from the body to meet with two laminae, which continue posteriorly immediately to form a spinous process. The transverse processes project laterally. On the upper and lower surface of the pedicles is a concave surface termed the vertebral notch. When the superior and inferior notches of adjacent vertebrae meet, they form intervertebral foramina. 4 articular processes, 2 superior and 2 inferior, arise from the junctions of the pedicles and laminae to articulate with adjacent vertebrae and form the zygapophyseal joints or facet joints. These discs consist of a central mass of soft semi-gelatinous material called the nucleus pulposus and a firm outer portion termed the annulus fibrosus. Typical vertebrae, you want to be comfortable and complacent with all anatomy. Vertebral body, vertebral foramen. The vertebral foramen was, in the case that I was speaking on earlier, is where the transverse process. And if you could take a look at this, you can maybe imagine the transverse process fractured into many pieces, comminuted. And the largest piece is lodged inside of the vertebral foramen. The piece that's lodged inside would probably be half the transverse process, so it was a pretty serious condition. So you have to be aware of that type of anatomy. The pedicle is closest to the vertebral body. The lamina is closest to the spinous process. Be familiar with all the anatomy. This image is on page 175. This is a lateral view of the thoracic vertebra. Thoracic vertebra spinous processes are rather large. And you should be familiar with all of the anatomy here, the body, the end plates, superior costal facet. The superior articular process articulates with the previous vertebra's inferior articular process, and that is the zygapophyseal joint. That is the facet joint. This image is also on page 175, and this is a sectional anatomy. We're getting into sectional anatomy here in the MRI, T2 weighted MRI of the lumbar vertebra. How do you know it's T2 weighted? The fluid is showing up bright here. Sorry. You can see the disc, the light colored disc, the nucleus pulposus of the disc. Here you can see the end plates very well, the vertebral body, the superior articular process with the inferior articular process, the inferior vertebral notch, and the superior vertebral notch make the intervertebral foramen. And this is the exiting point of the nerve. Lateral oblique view of the thoracic spine. Page 176. You can get an excellent peek at the zygapophyseal joint. So this image right here should give you a great idea of where and how the zygapophyseal joints look and are arranged. This image is on page 177. Axial T2 weighted MRI of the lumbar spine with the intervertebral disc and zygapophyseal joint. If you do a facet joint injection, they inject the steroid or anesthetic into the zygapophyseal joint. So that's a facet block. This is a T2 weighted image because the CSF is showing up bright. You can look inside of the vertebral column, and you see the axons. I'm sorry. Yeah, you see the axon ending. Here's the we econ. Again, the atlanto-occipital joint is from the C1 and the base of the occipital bone. Then you got the C1, C2 joint, the atlantoaxial joint is superior view of the C-spine. You can see the transverse foramina and the bifid spine's process because it goes off in two directions. Again, you have to be called to label the T-spine sometimes, or even the C-spine. So you have to be very comfortable with labeling the vertebra. The radiologist will have you do this so that they can interpret the images faster. So you have to be accurate. The top line is the line in front of the lumbar vertebra is representing the lordotic curve, and the sacrum is representing the kyphotic curve. And remember that the lumbar section typically consists of 5 vertebrae. Their massive bodies increase in size from superior to inferior. They're massive because they support a large portion of the body weight of the torso. So they have to be pretty large. The largest of the lumbar vertebra, L5, is characterized by its massive transverse process. The entire weight of the upper body is transferred from the 5th lumbar vertebra to the base of the sacrum across the L5-S1 vertebral disc, and that's why many times there's a subluxation of the L5-S1. That's why particular attention must be paid to the L5-S1. And in some facilities, you will be called to have do a oblique projection, axial projection through L5-S1. It's also important to provide the radiologist with an accurate sagittal section of the lumbar vertebra so that they can see or talk about any spondylolisthesis that may be present from a defective pars articularis. 3D CT, this is a shaded surface display image of the lumbar vertebra represented by the modality of CT. You should be familiar with all the anatomy here. There's not that much anatomy to actually learn and understand. You have the body, you have the pedicle, you have the transverse process, superior articular process, the lamina. Okay, so you got the lamina. The lamina connects the transverse process to the spine's process. The pedicle connects the body to the transverse process. So pedicle, lamina. Pedicle, lamina. This right here is the superior articular process, spine's process. Lateral view of the lumbar vertebra. Again, all anatomy is needed. This inferior vertebral notch meets up with the superior vertebral notch, similar to this. And this is where the nerve exits. Okay, so this red line would be the inferior vertebral vertebra superior vertebral notch. That's what this red line will indicate. And this is where the nerve would exit. The nerve will exit. If this was the spinal cord, we would call the nerve that exits here from this vertebral body. So if this is L4, L3 would be up there. The nerve that exits here would be L3. Like L2's nerve would exit out of the spinal cord about there. Okay. Be familiar with all the anatomy on this page as well. Nice mid-sagittal T2 weighted MRI image of the spine. Understand the thecal sac is a membrane of dormata that surround the spinal cord and the cauda equina. So that's what the thecal sac is. And, important to understand what the thecal sac is, because some iodinated contrast material you can't you you are not supposed to inject into the thecal sac. That's Iahexol Omni 350 is not for intrathecal injections, so you cannot use Omni 350 for intrathecal injections. The osmolality can lead to seizures or adverse effects from the iodine, the concentration of the iodine, if it indeed gets into the brain. However, Iahexol or Omnipate 240, 180 is adequate for intrathecal injection, so should be very familiar with those type of terms so that you can be safe with your patients. Again, understand all the anatomy on this image, especially like the conus medullaris. The anterior longitudinal ligament is this band of ligament that travels down the anterior portion of the vertebra. You have a posterior longitudinal ligament that travels down the posterior sections of the vertebra. And as far as lines, the radiologist looks at this anterior line, the posterior line, and he looks at, or she looks at the spinal laminal line and the line of the spinous process. Those are the four lines that the radiologists look at to understand if there is indeed pathology to the L-spine. So that's why it's important for you to get a correct mid-sagittal image of the spine, because if it's not correct, then the radiologist cannot fully evaluate these four lines to see if there is pathology and on the spine. Sacral. You see the sacral foramina, the body of the sacrum, the alo or lateral masses. It's the lateral masses of the sacrum. And the coccyx, which is the most inferior portion of the sacrum. Here it says 4 bones. It can be 2 bones. It can be 6 bones. But the most inferior aspect of the sacrum is the coccyx, or tailbone. So the sacral section consists of 5 vertebrae that fuse to form the sacrum. Located within the lateral masses are the sacral foramina that allow for the passage of nerves. The first sacral segment has a prominent ridge located on the anterior surface of the body termed the sacral promontory. The spinous process of the 5th sacral segment is absent, leaving an opening termed the sacral hiatus. Excellent mid-sagittal view of the C-spine, T2-weighted MRI cervical spine with the spinal ligaments. Remember, you have that anterior, posterior, spinal laminal, and then you have the spinous process line. So we got to make sure that we see all 4 of those lines before we present the case to the radiologist so that they can have a decent image. You have the foramen magnum, which should be present on all C-spine CT so that they can evaluate if the cerebellar tonsils protrude through it, which means there's a Chiari malformation. Spinal cord, medulla oblongata, pons, cerebellum. Spinal cord, posterior longitudinal line, spinal laminal longitudinal line, spinal cord. This is cerebrospinal fluid inside of the dural cavity. You have the prevertebral soft tissue. And remember, this prevertebral soft tissue, when we want to measure it, should only measure a couple millimeters. At the level where the esophagus begins, it can be up to 1 centimeter, 1.2 centimeters long. This is the epiglottis that folds down to stop food contents from entering the trachea. Continues on to the back, and then the esophagus will then peristalse from the constrictor muscles, pharyngeus muscles, and peristalse down the esophagus. C2. This is C2. And when you count this cervical vertebra, it is customary to count from C2. As long as you have the foramen magnum, you know you're going to have C1, but it's customary to count from C2 because it's easy to say C3, C4, C5, C6, C7. Another thing that you want to think about when you do the cervical spine is that the nerve that's exiting the cervical spine, unlike the T and L spine where the nerve is under the corresponding vertebra, and the C spine, the nerve is over. The reason why is because there are 7 cervical vertebrae. However, there are 8 cervical nerves. So where you have C7, you can have the nerve of C7, the nerve of C8, and it's the nerve of T1. Okay? So, and the cervical vertebra, remember you have 7 cervical vertebrae, but you have 8 cervical nerves. So during the T-spine, instead of the nerve exiting above the vertebra, it begins the nerve exiting beneath it. This is an illustration of a mid-sagittal view of the spinal ligaments. This image can be found on page 198, and you will be responsible for understanding all of the anatomy that is depicted here. The intervertebral disc. As the hyaline cartilage is just what separates it from the end plates of the vertebra. So you have hyaline cartilage, which you will be responsible for the nucleus pulposus, annulus fibrosus, vertebral body, spinous process. Why? Because you have to understand what a HMP is, or a herniated nucleus pulposus. You may receive a registry question that may just have letters. HMP. You have a patient with the HMP, and if you have no idea what the nucleus pulposus is, you wouldn't be able to begin to figure out what is HMP, herniated nucleus pulposus. And since we know that the L5 takes the brunt of the body load from the torso, we should understand that the L5S1 is most susceptible for herniated nucleus pulposus because it takes the brunt, and also it's curved, so it's easy for the L5 to slide anterior to S1 with the incontinent zygapophyseal joint. That's why it's important for you to understand these concepts. T2 weighted MRI of the thoracic vertebra with the spinal ligaments, sectional anatomy again, axial projection. You should be familiar with all the anatomy here. Anterior longitudinal ligaments, posterior longitudinal ligament, spinal cord, okay, epidural fat, spinous process, lamina. This is an excellent view of the intervertebral foramen, where the nerves exit. So when you are performing your examinations, quickly check to make sure that they're present. Okay, that you don't have too much tilt or rotation, that the doctor can't see these exit points, because if the doctor can't see this exit point, then there's no way to tell for radiculopathy, because radiculopathy is actually compression of the nerve that's exiting this foramina. Spinal stenosis is when you impinge on the spinal cord, but when that nerve comes out and is impinged At this point, you now have radiculopathy. CT of lumbar vertebra with the spinal ligaments. Again, be familiar with all the anatomy here. Good image of the zygapophyseal joint. Zygapophyseal joint. From the superior articular process and the inferior vertebrae inferior. This is the inferior vertebra, and this is the superior articular process of the inferior vertebra. So this piece of bone is not attached to this vertebra at all. This is attached to the vertebra underneath of this vertebra. This piece of bone is attached to this vertebra, and both of them come together to form the zygapophyseal joint. This is the bottom portion of the neuroforamina. So this would be the superior notch, and the inferior notch of the preceding vertebra. As a matter of fact, this is the nerve. That's the nerve that exited out. This is a nerve that exited out of the neuroforamina. MRI, T1 weighted MRI of the vertebra with the spinal ligaments. Image can be found on page 200. Again, you want to know all the anatomy here. And a new term here, we got the ligamentum flavidus dark line right there. That lines the posterior borders of the thecal sac. This is the thoracic vertebra. How we know? Because we have costal facets, okay, and we have a spinal cord. We have a picture of the rib, thoracic vertebra. And also we want to introduce the muscles, the rotaries muscle, multifidus muscle, semipspinalis muscle, ilicostalis muscle, spinalis muscle, longissimus muscle, and the trapezius muscle. Those are muscles of the back. These are deep back muscles. Okay. Muscles of the back can be separated into three groups or layers: the superficial layer, the splenius muscles; the intermediate layer, erector spinae group; and the deep layer, the transversal spinal group. The splenius muscles are located on the lateral and posterior aspect of the cervical and upper thoracic spine. Remember, we looked at the splenius muscles when we were looking at the neck. They're higher up. The splenius groups are higher up. And we have an anterior, middle, and a posterior. This is a posterior view of the transversal spinal muscle group. And apologize about the red line. My computer's a little touchy, so it's rather easy to mess up. Alright, well, the transversal spinal muscle consists of several short muscles that are located in the groove between the transverse and spinous process of the vertebra. Two additional muscles that are commonly visualized in the lumbar region of the spine are the quadratus lumborum and the psoas muscles, which are considered abdominal muscles. So the quadratus lumborum is this muscle right there, and they attach on the anterior side of the pelvis. But they also come up and attach to the spine. Just like the psoas muscle is adjacent to the lumbar spine. So if you see the psoas muscle, you know you're in the lumbar spine. You may see it sometimes at T12, but generally no higher than that. No higher than that. I'm looking at figure 463, a coronal CT reformat of the lumbar vertebrae with the spinal muscle. Shows a nice coronal section, CT image of the lumbar or the spinal muscle groups. T2 weighted MRI of lumbar vertebra with the spinal muscles. You can see the iliocostalis, the longissimus muscle, and the transversal spinal muscle very clearly. So you have the iliocostalis muscle right there, and you have the bottom portion of the longissimus muscle right there, and then you have the transversal spinal muscle. Okay, the quadratus lumborum muscle is there. Your psoas muscle is right there. Two important muscles to identify, because they can have hemorrhage or abscess formation in them. So you want to be competent to understand that the muscle is pathologic, so you can bring it to the doctor's attention immediately. Page 211 here, you see the conus medullaris, the very bottom piece of the spinal cord, the last piece of spinal cord that is going to have nerve bodies. The rest of the spinal cord inferior to that level will have axons. This image can be found on page 211. Throughout its length, the delicate spinal cord is surrounded and protected by cerebrospinal fluid, CSF, which is contained in the thecal sac formed by the spinal meninges. The dura mater is a tough outer layer that extends to S2, creating the thecal sac. The anterior thecal sac adheres to the posterior longitudinal ligament and is separated from the vertebral column by an epidural space that contains fat and vessels. The arachnoid mater is the thin, transparent membrane that is attached to the inner surface of the dura mater. The space between the arachnoid mater and the pia mater is the subarachnoid space, which is filled with CSF and the blood vessels that supply the spinal cord. The pia mater is a highly vascular layer that closely adheres to the spinal cord. So remember, the pia mater is pretty much inseparable from the brain, inseparable from the spinal cord. The dura mater is closely adherent to the spine, is closely adherent to the skull, and the arachnoid is the middle layer. The filum terminale descends through the subarachnoid space to the inferior border of the thecal sac, where it is reinforced by the dura mater. In addition, lateral extensions of the pia mater leave the spinal cord to form pairs of denticulate ligaments, which attach to the dura, preventing lateral movement of the spinal cord within the thecal sac. Okay, this image can be found on page 217. Yes, 478. Axial T1 weighted MRI of the conus medullaris. So the illustration to the left of the picture is demonstrating the view of this picture. So the spinal cord functions as a large nerve cable that connects the brain with the body. The conus medullaris is the most inferior portion of the spinal cord and is located at approximately the level of T12L1. The spinal cord is composed of white and gray matter. The white matter myelinated axons comprises the external borders of the cord and is more abundant. The gray matter is composed of nerve cells. It is centrally located and surrounds the central canal. The dorsal horns contain neurons and sensory fibers that enter the cord from the body periphery via the dorsal roots. The dorsal root ganglion, an oval enlargement of the dorsal root that contains the nerve cell bodies of the sensory neurons, is located in the intervertebral foramen. The ventral horns contain nerve cell bodies of the efferent or motor neurons. Axial T2 weighted MRI of the cauda equina. So you should be able to identify the thecal sac, the cauda equina, and the epidural fat. CT image of the cauda equina, so you can appreciate the difference. But on this image, what modality? Well, we already said what modality is CT, but this is a specific test. Give you a second or two to try to figure out what specific test this is. One American, two American. This is a CT myelogram. You can see that they injected contrast material inside of the thecal sac. So that's actually contrast. You wouldn't be able to see the cauda equina, the little tips of the nerve cells, the little axon endings of the nerve cells, if you didn't add contrast to the thecal sac. It would blend in together. It's a good view of the spinal cord continuing to the brain stem. So we have a picture of the central canal of the spinal cord that continues on right into the brain stem, the pons. So this is a coronal T2 weighted MRI of the brain and spinal cord with the central canal. Lateral ventricle, lateral ventricle. And the septum pellucidum, you have up here the corpus callosum, which is a band of white tissue that connects. You can see that you have a gyrus right there. You have a sulcus right there. So this is one hemisphere, this is another hemisphere, and it's connected by the corpus callosum. T1 weighted MRI of the spinal cord with ventral and dorsal roots. So you have the ventral root is just the anterior portion of the cord. The dorsal root is the posterior portion of the cord. So just be familiar with all the anatomy. There's only three things to learn here: the ventral root, the conus medullaris, and dorsal root. This is an illustration of the spinal cord and the exiting nerve. So you see that the nerve is extending from the spinal cord of the superior spinal cord, traveling down the dural sleeve. So it's traveling down. This is the dural sleeve, so that's a portion of the dura mater, and this is the nerve going through the neural foramina of the disc. This is the dorsal ramus, the ventral ramus. So this goes in front, this goes in the rear. And when there's an epidural injection, the needle is placed right there. So epidural injection is going to anesthetize this portion of the nerve. So therefore, whatever this nerve innervates should no longer feel as much pain. Okay, you can see the pia mater is closely adherent to the nerve, the subarachnoid space. So this is the pia mater right there, subarachnoid space. This is the subarachnoid. The arachnoid layer. This is the dura mater. T2 weighted MRI of dural nerve root and dorsal root. So be familiar with the anatomy here: the thecal sac, the dorsal root, lumbar spine, the dark portion is the lumbar spine, and the psoas muscle coming off, going down adjacent to the L spine. Illustration: posterior view of the spinal cord and the meninges. And here's a good time to notice C8. Remember we talked about C8 earlier. There's 7 cervical vertebrae, but there are 8 cervical nerves. That's why above the cervical vertebra, the nerve exits with the bone. Beneath it, the nerve exits beneath it because of that extra cervical vertebra. And then you see the conus medullaris here between T12 and L1 ends pretty much at the L1 level. You see a good picture of the thecal sac, the cauda equina. And this is a cross section of the spinal cord, and you can see the difference between the cervical, thoracic, and lumbar spinal cord. You have the anterior median fissure that comes right down the middle parts, like the falx of the brain, if you wanted to. Try to compare it to something. This image is found on page 224, by the way. So you have, white matter and gray matter. White matter, remember, is the myelinated sheath. The gray matter is the actual nerve bodies. You destroy the gray matter and it cannot regenerate. You don't want to do that. You have the sacral cord. You have the ventral horn and the dorsal horn. Ventral horn, dorsal horn. You have, here they have the dorsal horn. The ventral horn is up in this region, dorsal horn. T1 weighted MRI of the cervical spine and cervical cord. And from here, you have to understand that these nerves come out in bundles and groups called plexuses. You could read along on page 226 and with our discussion of plexuses. The spinal cord is enlarged in 2 regions by the cell bodies of nerves that extend to the extremities. The cervical enlargement extends from the vertebral bodies of approximately C3 through C7, and the lumbosacral enlargement occurs within the lower thoracic region. Cross-section images of the spinal cord at various levels have considerable differences in size and shape because of the changing proportion of gray and white matter. T1 weighted MRI of the conus medullaris at T12. Page 228. Again, you want to understand all the anatomy, just the ventral root, the conus medullaris, and the dorsal root. Illustration of the distribution of the ventral and dorsal rami and transverse sections of the spinal cord. So you had a ventral root right there. It comes from the ventral horn, dorsal horn, and the dorsal root. And information actually travels in a circle here. I'm going to try to draw it. So this is how information goes. Okay, so information goes up and throughout. As a matter of fact, we could talk a little bit about the reflex process and what a reflex is. A reflex is when the nerve endings respond before the brain can even analyze what's going on. So when you get the stimuli into the spinal cord will enact a reaction while sensory neurons is moving the information to the brain. So while the sensory neurons is moving the information to the brain for analysis, other efferent neurons is forcing a motor response from the body. So a reflex is something that happens prior to the body analyzing that it can happen. And this is a demonstration of a reflex. So shortly after emerging from the intervertebral foramen, each nerve divides into dorsal and ventral rami, which contain both motor and sensory fibers. The dorsal rami of all spinal nerves extends posteriorly to innervate the skin and muscles of the posterior trunk. The ventral rami of T2 to T12 pass anteriorly as the intercostal nerves to supply the skin and muscles of the anterior and lateral trunk. The ventral rami of all other spinal nerves form a complex network of nerves called plexuses. Brachial plexus, cervical plexus, lumbar plexus, lumbosacral plexus, and the sacral plexus. These plexuses serve the motor and sensory needs of the muscles and skin of the extremities. The four major nerve plexuses are again the cervical, brachial, lumbar, and sacral. The cervical T1 weighted MRI of the cervical plexus. The cervical plexus arises from the upper four ventral rami of C1 through C4 to innervate the neck, lower part of the face and ear, the side of the scalp, and the upper thoracic area. The major motor branch of this plexus is the phrenic nerve, which is formed by the branches of C3, C4, and upper division of C5. That's the phrenic nerve. Phrenic nerve is the diaphragm. C3, 4, and 5 keep a fella alive. You dislocate or fracture that plexus and you cannot breathe. Leads to a condition very susceptible to demise, death. Sagittal T2 weighted MRI of the cervical plexus, page 231, I believe. The phrenic nerve, which innervates the diaphragm, is formed by motor fibers from C3 to C5. A primary danger of a broken neck is that an injury at or above the level of C4 may result in paralysis of respiratory muscles, resulting in breathing difficulties and impaired speech. So you can't even tell them that you're having difficulty breathing. And here's the scalene muscles. Again, the anterior, middle, and posterior scalene muscles of the neck. We learned this in the chest. Anterior oblique view of the brachial plexus. So you see how the brachial plexus is closely related to that scalene group, that upper trunk and middle trunk and lower trunk of the brachial plexus, closely related to the scalene muscle group. 232, brachial plexus, page 232. The brachial plexus is a large complex network of nerves arising from the five ventral rami C5 through C8 and T1. The roots of the brachial plexus emerge between the anterior and middle scalene muscles, where they continue laterally and inferiorly to divide into three cords just posterior to the clavicle. The cords extend through the axilla to form five terminal branches. The musculocutaneous, axillary, median, radial, and ulnar nerves come from this brachial plexus. Remember, you can pause, you can go back, and re-listen to things that you may have missed. This is page 234. This is an axial T1 weighted MRI of the brachial plexus. They have on 234. They have an illustration just above this, just in case you need some help with that. But here you want to be able to identify, of course, the trachea, thyroid, jugular, the anterior scalene muscle, the common carotid, the brachial plexus, the middle scalene vertebra, spinal cord. These should all be very familiar to you at this point. You want to be able to understand all the anatomy on this page: the pectoralis major, clavicle, serratus anterior, trapezius, supraspinatus, subclavian vein, subclavian artery, brachial plexus. We talked about these muscle groups, nerve groups, and vascular bundles. This image can be found on page 236. Okay, figure 4.115. And then we're down in the lower lumbar region. Understand the anatomy here. Psoas muscle, lumbar nerve. So that's a nerve extending from the lumbar region. You see the pedicle, the segmental artery. Segmental artery, I doubt if you see that in the test. But the thecal sac and SI joint, fair game. The lumbar plexus arises from the ventral rami of T12 and L1 through L4. The lumbar plexus is situated on the posterior abdominal wall between the psoas major muscle and the transverse process of the lumbar vertebra. So here we're further down into the pelvic region, and this is still including the spine. The sciatic nerve branches straight off of the plexus, and therefore included in this discussion. So you should be familiar with all the anatomy. And the IT band is the iliotibial band. Okay, so IT stands for iliotibial band. But we talked about the gluteus maximus. The greater trochanter will be discussed in the lower extremity. But the sciatic nerve, acetabulum, femoral head, femoral vein, and artery are actually discussed in the pelvis. So yeah, we should be familiar with that at this point of the discussion. So this image can be found on page 245. This is a CT image of the lumbar vertebra injected, because you see the aorta right along with it. Good picture of the aorta. But you see the arteries that's coming off of the aorta to feed the spine. These are the segmental arteries. So they're little arteries that come directly off of the aorta, and they feed the spine. And this is the venous drainage of the vertebral column. So, and we will always see this basivertebral vein coming up. And you have to understand that is not a fracture. You see that Y shape of the vertebral body, and many novice imagers will call it a fracture. It's not a fracture. You're actually imaging the basivertebral vein. And indeed it's necessary for it to be there, because that's how blood drains back into the major vessels, which is the vertebral venous system. That's it. That's it for the spine. I would like to go back to this slide, 'cause I want to talk some more about the veins of the spinal cord. The veins that drain the spinal cord follow the same segmental organization as their arterial counterparts. The central gray matter of the cord is drained by the anterior and posterior central veins, located in the anterior median fissure and posterior sulcus, respectively. The anterior and posterior median veins drain into the anterior and posterior radicular veins that parallel the ventral and dorsal roots, and eventually empty into the intervertebral veins that accompany the spinal nerves through the intervertebral foramina. You may have to go back over that, but it's important to understand. Because the vertebral venous plexuses are valveless, an increase in intra-abdominal pressure, such as coughing, may cause backflow of blood into the basal vertebral veins of the spine or dural sinuses of the brain. So remember that the veins pulsate blood back to the heart through muscle contractions, movements, gravity, things like that. The walls do not pulse the blood back to the heart. So therefore, if an increase in intra-abdominal pressure can stop the flow of blood going back to the venous system and going back to the heart. And I just wanted to go over that. See you for, I believe, the upper extremity.